Good afternoon again, everyone. Thank you for joining us. And without further ado, let's kick off our Mission Health Equity Challenge Series, Challenge number 2, book discussion. We are really excited to have Dr. Jay Bhatt from the Deloitte Health Equity Institute. He'll be presenting first. Dr. Bhatt is a physician, executive internist, geriatrician, and public health innovator. As executive director of the Deloitte Center for Health Solutions and the Deloitte Health Equity Institute, Dr. Bhatt directs the research, insights, and eminence agenda across the life sciences and healthcare industry while driving high-impact collaborations to advance health equity. He is a prominent thought leader around the issues of health equity, healthcare transformation, public health, and innovation. Passionate about patient care, Dr. Bhatt continues practicing medicine at local community health centers in Chicago and Cook County while serving in his leadership role at Deloitte. Dr. Bhatt, the floor is yours. You may share your slides.
Excellent. Thank you, Jaleese, for that kind introduction. Great to be here with you all this afternoon. I am born and raised in Chicago. I'm the son of 2 South Asian immigrants. My dad, a pharmacist on the south side of Chicago, my mom, a factory worker, and spent a lot of my time growing up in underserved communities. And it's in my professional life purpose, passion of caring for the historically underserved, historically vulnerable, and historically marginalized communities. So really grateful to do this work with Deloitte and grateful to be with you all. Thanks again for your leadership and work in clinical translation. And I love this collaboration among the institutions in Cleveland. And I'll offer some thoughts and open it up to questions and dialogue, but certainly stop me along the way. You can, if you want to raise your hand, but Jaleese can maybe keep me honest here and call folks out if there want to be questions and comments. So the Deloitte Health Equity Institute is relatively new, about a year and change old, and it emerged from the inequities that were illuminated by COVID-19 and the importance that we saw around addressing those, and particularly growing need in both life sciences and healthcare, but also in government and public sector, and across other industries, from technology to consumer. We're seeing health equity as being an important issue, as well as in financial sector, as well as the area of education. And inclusive prosperity is certainly another element of this. So we define health equity as a fair and just opportunity for everyone to fulfill their human potential in all aspects of health and well-being, not only the clinical issues, but also the drivers of health. And we've got a schematic, the drivers of health wheel, that illustrates those intersections. Our recent evidence and our imperative suggests that this is not only a moral imperative, but certainly the murder of George Floyd and the way that discrimination, racism shows up, but also poverty and the impact on access. And this is the right thing to do for people in our country, but there is also a business imperative. We recently put out a report that shows that the cost of health inequities is $300 billion today, likely an underestimate. And I'll share some of the ways that we approach that to get to that number. And $1 trillion by 2040 if we don't adopt a future of health vision, which is Deloitte's perspective on the evolution of how we think about care sites, digital, virtual health inequities, and the integration that needs to happen within the sector. That means $1,000 today for each individual and $3,000 in 2040. So we say that health equity is a moral imperative that requires business solutions, and in some ways we're uniquely positioned to help move mindset, shift practice, and transform the organizations and the communities we work in. So we work closely with our client services team as the Health Equity Institute, and anything we do at the Health Equity Institute is for the public good. We make philanthropic investments that offer pro bono services, but also co-create with community-based organizations. And I'll share some examples of that in a moment. But we also work with our Center for Health Solutions on the research and insights agenda, and in the areas that we prioritize, both on disease states or conditions, as well as levers of change, which I'll speak to in a moment. We also have organized a framework, the 4 domains of action, how we work with our clients, and more importantly, to start with how we work within our own house. So our policies, programs, and data and technology assets, putting that through an equity lens, thinking about our workforce, our offerings, putting our products and services through an equity lens. And then community is what I just referenced with our work with the Health Equity Institute. And there's a broader ecosystem of bringing fragmented stakeholders together. And that's both also policy actions and system and environmental actions that happen. So that's the framework we use with our organization and certainly with clients, but also with our work at the Health Equity Institute with community-based organizations. And this is a journey. We've got more work to do here. So the aspiration for the Health Equity Institute is to move the field to achieve health equity as an outcome. And as someone that practices at community health centers in underserved communities, I see this as incredibly important, but also very personal. And we could do everything right clinically, but people go back to the conditions that make them sick. And so that's part of why I think that the left box shows the 3 inextricably linked root causes that prevent equitable health outcomes and what we're working to address. 1 on racism and bias inside and outside the healthcare system. 2, the deep inequities and non-medical drivers of health. And we connect this to place-based change and place-based inequities, which I think are incredibly important. Again, with this point about the investment in communities that are needed that have been historically underinvested in. Structural flaws in the health system. So then we drive change from a purpose-first lens through these 3 levers. Strength place-based change, where we bring fragmented stakeholders together to create proof points for high impact change and work on issues like COVID-19, maternal and child health, and women's health, sexual and reproductive health equity. Drive health equity innovation through scalable change, where we're supporting social entrepreneurs and creating data tools, data dashboards, like we've done with March of Dimes, where we have our data combined with March of Dimes data to create a data tool that shows maternity care deserts with other characteristics in those communities that can impact the outcomes of maternal health. And then activating key decision makers, creating a domino effect of actions and change among those that are influencing organizations, boards, communities. And so we work with the Black Directors Health Equity Agenda on a playbook that we've produced, and the World Economic Forum, where 26 organizations are coming together in a global health equity network to take actionable make actionable commitments on sustainability, climate, and equity issues. And we have a purpose office led by Kwesi Mitchell, Chief Purpose Officer, that's really helping support our work, as well as the work of educational mobility and financial inclusivity and prosperity. And so we do this work at the Health Equity Institute in a number of different ways. We can be very creative. Philanthropic investment, as we've done with some of the examples shown here, United Way, Robin Hood, Unidos, Partners in Health, and there are a number of others on specific issues where we're trying to connect the investment with a research question. So for example, on decision makers, we're saying there's some data and there's anecdotal evidence that suggests that if we diversify and create an inclusive space within leadership teams and boards, that may lead to equitable outcomes. Now, this is an opportunity for us to test that and see what works on leadership team and boards to lead to those outcomes, both from people and voices and their perspectives, to the ways that the conversation's happening and the structures and supports there to do that. So that's one example. Another is around community health workers. It's not scaling in this country. You know, what are the reasons why compared to other places around the world where it does? And so trying to deal with both reimbursement, workforce, and training and integration into care teams. Co-publication, we did a recent piece around race and ethnicity data collection and commercial health plans with Urban Institute and Elevance Health, which is a large payer. And then analytics and research was the example that I've given before. These are some examples of our collaborations. You'll see in each of those 3 levers of change where we've had meaningful impact, impacting nearly 20,000 people across our 23 collaborations directly and nearly 2 million people indirectly. And then we're learning through these interactions and collaborations, and we're publishing on the impact and the learnings from that. And so I encourage you to go to our website and check out more of the work and the thought leadership and the resources that are available there. We're also working, again, as I said, on research, where we're using research to drive answering questions that emerge from the community collaborations, or also strengthen our impact and measure opportunity with those collaborations. And then we have a data and analytics effort where we're developing a charticle series. This coming out soon is one around literacy and health literacy and the impact that has on health equity. And you'll see some examples of playbooks and visualization tools that we've got on our website. These are some examples of thought leadership, particularly the drivers of health is an important one, where 78% of health organizations say that they're asking about patient housing needs, but only 32% are connecting their services to help with identified needs. So there's a gap, certainly in community-based support and resources for that, or how to do that work. Clinical trials, diversity, women's health, those are just examples. This is a piece I referenced earlier about health inequities accounting for $320 billion in annual healthcare spending, which is a crisis for the industry. This builds on the report from last year, Breaking the Cost Curve, which looks at how new business models, tech breakthroughs, consumers with particular data and particular regulations could decrease healthcare spending. And we know that if addressed, it could grow too big. And this will require partnership. It's too great for one institution or organization to solve. So this is what we see as the growth of healthcare spending that we talk about in the report. The current trajectory at 5.3%, health inequities is accounting for 6.2%, or expenditures for this population, nearly 6.3%. And then the breaking the cost curve, the vision of the future of health that Deloitte has can trend at a much lower rate of that spending at 3.7%, also needing to account for the health inequities that are within that. So we see that there is an opportunity with a different way of delivering care and paying for care, where it's oriented around the care model and supporting those around prevention and care effectively, that we could impact spending and outcomes. So this is how we looked at the issue of cost of health inequities. We took 5 chronic and preventable conditions and looked at the annual costs with the disease, and then what the population differences are in terms of spending. So we see for example, in breast cancer, 9% of Black women are diagnosed with breast cancer when the disease at an advanced stage, compared with 5% of white women. That's going to cost more as a percent. It's a 0.4% spending associated with the disparity, and the potential cost savings for breast cancer alone, $57.4 million. Now, there's a lot more that goes behind the model related to this and the methodology, but this is at a high level to simplify it, what we did. And this doesn't account for unavoidable care or complications or mistakes that may happen, or errors that may happen within the care delivery setting. Diabetes is another example, where we're seeing Black adults 60% more likely than white adults to be diagnosed with diabetes, and 2 to 3 times more likely to have complications, which has an associated 4.8% disparity of spending, which takes from the annual cost of the disease to what the total potential cost savings are. Now, the other thing I'd say is even the question. So this is not race and ethnicity is disproportionately impacted, but it's also about gender. It's also about place. It's also about veterans, also about people with disabilities. So one rural Georgia hospital asked the question, what's the difference between men and women on diabetes readmission? Women are getting readmitted at 22% versus men at 12%. And they worked over 3 years to close that difference. But it's also, these questions can be asked, and you'll see a recent New York Times article talking about we've made scientific and technological advances in both treatment and diagnostics, yet we're still seeing more diabetes. And so that goes back to community, drivers of health, people in conditions that make them sick. So, we march that out for these others. And now this is some of the media that attention that the piece has gotten. And so encourage you to take a look at that as well, which will dive into some of the perspectives we have on this issue that can give you more insight. And we have a Health Equity Institute in Africa, and we have one in India, and they're working on different things. India just released a piece on mental health in the workforce. And in our work, mental health, women and children's health, chronic disease, including diabetes and heart disease, as well as finishing up some of our work from COVID, is our priority areas. And then we look at workforce development and drivers of health as issues across those disease conditions as important ones to the lens to look through them by. And this goes back to some of what I talked about in an example of organization, how an employer addresses diversity, equity, inclusion in the workplace versus offerings, the products and services they deliver. We're working with a big technology company around their technology product and put an equity lens on design, implementation, and monitoring. So this is the drivers of health wheel that I was referencing, where health equity is centered, and then there's other elements that support sustaining well-being and receiving care, and the environmental, economic, and social influences and structures around it. And we actually, recent report at Food is Medicine that looked at inflation and the high cost of prices on healthy food and what grocers can do in that regard. So that's an interesting piece and analysis that just came out last week. And we have another piece that came out this week on alternative care sites, where we've looked particularly at people of color and their engagement with alternative care sites, where you find interesting ways that underserved communities are accessing mental health and prevention virtually, but also managing chronic disease, and that last mile, giving more access points consistently and helping them understand how to navigate through them, we found really important. This is just examples, of equity quality measurement systems. So we're seeing it in CMS through government, where they're trying to infuse an equity lens in their specific areas of CMS stars, HEDIS, and MIPS. And CVS, for example, is an example of one that looks at that, as well as others. And these are just some additional examples of publications and that we've had. So the one I referenced, U.S. healthcare can't afford health inequities. Activating health equity is a foundational piece. It provides a framework on how to engage in this issue and talk about it. And then others you can see through on various issues. So encourage you to look at those on the website, and would love to talk further and engage and collaborate. We're looking for academic and clinical translation partners on some of our research. And so we'll look forward to continuing the conversation. But I'll stop there and see what we can talk about. And FPL is the federal poverty level. So.
All right, thank you, Dr. Bhatt. So along the same lines, continuing what you just announced about looking for academic research partners, how would someone get in touch with the right contacts, or is there an application process? How would our researchers access those opportunities?
Yeah, so one, I'll say we're working through a process for that and bringing together a collaborative coalition of academic partners. But if you're interested in engaging in that, you can send me an email, which I've put here, and I'll route it to our team. But we're also, with our specific collaborations, looking to evaluate and measure impact. We have a health equity researcher on our team who can engage in conversation around some of the collaboration opportunities. Again, we don't have that spelled out yet, but it's a work in progress. But we're happy to talk through at this point, on individual kind of conversations.
Okay, excellent. And will these slides be shared with the group? Is that possible?
Yeah, what I can do is I can send a PDF to you, Lisa, and share these with you that you can share out to the group.
Okay, thank you very much. Any other questions? If you'd like to put those in the chat.
And I think it'd be interesting if there are comments about what trends or things any of you are seeing from your research and work there in the Clinical Translation Center. Anyone wants to speak to particular things that are resonating in terms of trends or issues or insights that are emerging.
That's an excellent question. And if anyone would like to respond, please feel free to take yourself off mute.
I had a question. We're part of this health equity challenge is to evaluate what sort of effects it's having. And as a researcher, I can pretty easily come up with outcomes that researchers would have as a result of learning a lot more about health equity. I'm struggling though with community outcomes. If community members attend these events and learn about these things, what sort of outcomes would come from those seminars, these seminars?
Yeah, I mean, so, you know, we talk about this work with a wide range of organizations that we work with or are wanting help in particular area. You know, we also do, so on strength and place-based change, we've brought a coalition together in Greater Washington, Maryland, Virginia. This particular effort with United Way is around vaccinations. So measuring that 15,000 people got vaccinated, the number of organizations involved. Now, some of the metrics may take a longer period of time. So here's Robin Hood is another example. And some of the place-based metrics will take a while. So life expectancy is another, which again is not a short-term issue, but Westside United in Chicago is saying that our aspiration is to reduce the life expectancy gap among populations on the west side of Chicago. And that's a long-term game. And so there may be intermediate metrics around the impact they're making on that North Star, but that there is, you know, is there supplier diversity happening? Is there vendor diversity happening? Is there change in the workforce composition to reflect the communities that the organizations serve? The other is environmental climate. You know, are we seeing certain changes there in air quality or others? So direct intervention can contribute to that, but there may be also indirect, which is harder to measure. But you know, I think this is a work in progress. And one piece I'll share also in the email is a quantification of neighborhood social determinants of health. So we've got these indices, social vulnerability and others, but it looks at things in a one-dimensional way. When you intersect drivers of health in a geospatial context, you see a different story in terms of how the different drivers of health relate. The other is, you know, this on activating key decision makers. You know, we're working on a measurement framework for the World Economic Forum, but on the Black Directors Health Equity agenda is how are this playbook being used and what changes are being made as a result of use of that tool. So that's some of an example of outcome measure, but it's not, you know, I think your point is well taken that it can be a difficult thing.
Well, especially since it's a talk, right? Or it's a screening of a movie about health disparities. You know,
Oh, you're talking about in your specific context.
In this health
okay.
equity challenge series.
Yeah.
Like I would not expect, you know, life expectancy to be a reasonable measure.
Got it.
That's just not a reasonable measure for this.
Yeah, I agree. So my apologies. Let me say my view on in this context around the book series is a pre and post assessment around how people's perspective change as a result. Questions related to their own sense of bias and understanding. Are they more equipped to engage in particular conversations with community members that are in underserved communities or historically vulnerable, marginalized? That's one example. Does it catalyze a set of other conversations or interventions in the community as a result, you know, of these conversations? So that's you know, several examples of how the book series potentially you could measure the impact about what actions or attitudes or values are impacted as a result over this experience.
Thank you. That was simple.
Thank you very much, Dr. Bhatt. I know we're coming up on the 12:30 mark.
Yeah, if there's one more I can take, if anyone has a comment or question.
Hi, I admittedly, my name is Rachel Oscar. I admittedly do not work in research, but I work in philanthropy and funding health and human services. But wondering if there, and forgive me if you've already touched on this, but if there's any intention to kind of take the research and use it in an advocacy context, or fund efforts that then go to either local or federal policy change?
Yeah, we work closely with our government public sector colleagues at state and federal levels to take some of our research learnings and learnings from the community-based organization to address, for example, maternal health policy, sexual and reproductive health, chronic disease, virtual telemedicine, and virtual and digital care delivery for underserved communities. So there are those. And the philanthropy work that we do may lead to, for example, the example I did we talked about Elevance, American Benefits Council, and Urban Institute. That paper is now being used in different ways to mobilize policy discussions and calls out federal actions or state that could be taken to help address data collection, race and ethnicity-based data collection.
So is there anything in particular that you guys have your eye on right now, or that we should be aware of?
I think it relates to sexual and reproductive health, community health workers, maternal health, and chronic disease, but we're also looking at workforce development programs and then other policies that impact drivers of health, from housing to food insecurity to transportation. But we, as an organization, have are figuring out what are specific things we collaborate with our policy team on, because we just have to be careful and thoughtful about how we do it as a philanthropy and part of a partnership that is built.
Makes sense. Thanks.
Yeah, thank you for the question. But we'd love to connect with you, Rachel, offline, and hear about and can talk further and connect you with our team.
Wonderful. Absolutely.
Thank you, Rachel, and thank you, Dr. Bhatt. We are so grateful that you were able to join us and help us kick off challenge number 2. And we look forward to passing along this information and potentially having some of our researchers be able to collaborate with your institute.
Great. Thank you so much, Lisa. And I just applaud the tremendous work you all are doing in this challenge. I think it, again, really important in the pathway and journey towards health equity. And I think the other piece of this that's important is language. Language matters. The language we use to talk about health equity really means in level of poverty, discrimination, bias, lack, differential opportunities and supports, and then where we think about in terms of social needs. Like I'll give you the housing example, helping one of my patients get better housing or address housing challenges in their own home with tenants' rights organizations as a social need. The lack of affordable housing is a driver of health and a social determinant. And the history of decades of policies that create the inequity is a systemic or structural issue. So it also matters where you're investigating or where you're intervening, understanding that continuum in the language, because it often gets jumbled together.
Absolutely. Thank you so much.
All right, thanks. Have a good one. Appreciate it.
You too.
Bye.